my name is Armstrong, and I'm currently working for the Children's HIV Association Africa, CHIVA Africa, as the Adolescent Program Coordinator. And we're based in Durban, and we do capacity building, mentorship, and training for healthcare professionals. Originally starting off with pediatrics, and now we've moved more into doing adolescents. So we do workshops. At the moment, we only have funding for KwaZulu-Natal, and we do one-day workshops for all different types of healthcare professional. So what I'm going to do today is just go through just a little bit of introduction to young people living with HIV and the growth and the change that all young people experience, but specifically those who are living with HIV, and then look at that impact on us as healthcare workers and health services and how we deal with it. Then I'm going to have a few focus areas, I think things that are imperative from my own practice and other people's practice, things that we need to be able to master when providing treatment and care for young people living with HIV. And that's communication, adherence, disclosure, sexual reproductive health, and then providing youth-friendly services. So how does that sound for you today? And what I'm going to do is I'm going to mixture in some the latest research, hopefully focusing mostly on sub-Saharan Africa, although that we're a bit of there's not that much going on. So I'll do my best to, string out what is available. Then I'm going to give you some perspectives of young people living with HIV, adolescents living with HIV, and then I'm also going to give you some practical principles. So when you go back to work tomorrow, hopefully that can help you as well. Okay? So just some recent numbers that have come out. So this is from the UNICEF document that was produced last year. It just gives you a bit of an indication of how many young people around the world are living with HIV at the moment. And you can see there that 1.5 million are living in sub-Saharan Africa. And the highest numbers are in South Africa, other African counterparts, as well as India. In South Africa, the numbers at the moment, this is the only stuff that I can find that's published, and unfortunately it's only from 2008. But we currently, they say, as of 2008, have 334,000 children under the age of 15 living with HIV. I guess that was before we had real concerted efforts to test. And then you see, in terms of also young people, I guess you could say 15 to 24-year-olds, there you've got percentages there for women and men. But we would expect that that's a lot higher. And also we know that we're starting people sooner on treatment. So the number of children and young people on treatment are also going to be a lot greater than we were experiencing back then. So hopefully we'll get some new data. If anyone knows of any other published available data, please do let me know, because I can't find it anywhere. All right, so a time of growing and changing. Adolescence is a period of exceptional growth and development. The only rate of growth that is faster is during fetal life and infancy. But in that period, there's not as much variation as there is in adolescence. So these changes of development that is happening, it's both physical, physiological, their bodies are changing, their moods are changing, their emotions are changing, how they relate to their families changes. It goes more towards their peer focus. It goes more towards people who were once maybe their models would be in their parents, and then that changes to pop stars, idol, all those people, that's who they're looking to. So in that period of adolescence, there's so much change in every single aspect of their life. And when we say adolescents, we're meaning 10 to 19. When we say young people, we're meaning 15 to 24. So even that, there's variation as well. But even in those stages of adolescence, you've got early adolescence, you've got mid-adolescence, late adolescence. And all of that, all of that changes for a young person. So maybe when they're starting out, their cognitive thought processes may be quite concrete, and what's happening in front of me is what's happening now. Where they move to middle and late adolescence, and their thought processes become more abstract, where they think a bit more about consequences. They think more about how their actions can affect their life tomorrow. And we know that the brain continues to develop into early adulthood. And this continued development really impacts on social problem solving, regulating their emotions and moods. So for all young people, young adolescents, that change that is happening can vary for an individual. Okay, so we all know, even in my own family, I'm one of 4 girls. we all went through those changes at very different paces and in different ways as well. And because I'm the youngest, I always swore that I was not going to go through puberty because I had been through my 3 older sisters. Didn't quite happen that way. So when we think about the added impact, the effect of young people who are living with HIV, I first want to look at those who are infected from birth. So there's quite a lot of extra things that they are having to cope with, not just those normal adolescent changes, but a whole heap of extra things. They start off coping with a lifetime of illness, of attending clinic on a monthly basis in some places. And lots of them often don't know their diagnosis. They don't know why they're attending clinic every month. They have parents and carers who are aware of their status, and they themselves also have their own burden as well of their own diagnosis or having to access their own care as well. There might be also a bit of a struggle between healthcare workers and parents to provide good care for those young people. And also for the young person, it's the fighting against independence. I know that we used to say that pediatrics is like wrapping them up in cotton wool, protecting them for as long as we can. And then adolescent care is like providing a safety net. So we let you to go and, do your own thing, but if it doesn't work out, we're still there to catch you anyway. And then adult care, you're on your own. So it's that initial part of wrapping them up in cotton wool and protecting them as much as we can and not harming them. And then the young person fighting against the feelings of wanting to be independent in every single aspect of their life. So it's kind of normal that you expect it to happen in healthcare as well, have control over their health and make decisions as well. That some young people, and I know quite a lot that I looked after in the UK, there was definitely an expectation that their parents and people around them thought they weren't going to make it into adulthood. So possibly the expectation and the maybe, I guess, pressure with school and extracurricular activities, it wasn't quite as there as it is for other young people. So they're facing that as well. Then there's delayed puberty, stunting. Who here in their clinic sees young people and you think possibly they might be 10 and it turns out they're 17? Has anyone experienced that? Yep, I've definitely experienced that. And one of my patients, he's probably that tall, and then his younger brother came with him to clinic, and his younger brother was that tall. So the effect that has on a young person's the self-esteem, the way that they view themselves, the way that they compare themselves. Remember, we were talking about how you compare yourself to your peers. That greatly impacts on them as well. Then there's long-term side effects. Again, this is going to be affecting the way that they view themselves, whether it's facial lipoatrophy, lipodystrophy. They could be experiencing pain from neuropathy, long-term side effects of medication. And then there's also those who have kind of skin problems or chronic lung disease. They're going to look different, or they might have to go into hospital more often. And then there's more questions from friends or family. Why are they constantly sick, or why does your skin look funny? So these are all added extra impacts. And then it's concerns about, will I have a normal sex life? Will I be able to have kids? Can I have a family? And then there also a lot of that desire to have a family, in my experience from the young people I've worked with, is that they go through so much loss, and a lot of them have been brought up, whether it's orphanages or foster care, or they move from one auntie to the next auntie, to the cousin, to the sister, and it becomes such a desire to have your own family, to create your own close body network, because you've never really experienced that before. So yeah, those are just a few of the things, the extra things that are that young people living with HIV have to cope with as well. So those that are affected during adolescence, they cope with the impact of a diagnosis, whether they tell their parents or not, whether they cope. There's a lot of isolation where they're coping it by themselves. There's that intense fear of rejection from maybe established sexual relationships. And then also they come with their own knowledge and their own preconceived stigma. They come with that. So I've had one young person who was diagnosed. She said to me, "But Alice, I was making fun of someone that had HIV last week, and then I found out that I had HIV." So I came with that. You know, when I got my diagnosis, I already came with that discrimination towards myself and having to deal with that. And then also they have preconceived ways of how they view health services. Lots of them have never attended clinic before, you know, and they get diagnosed and all of a sudden they come into this world of healthcare, which to us it's normal, but to most young people it's not normal. They don't normally attend clinic. Also, a lot of them may have, when they come for diagnosis, they may also be quite unwell, and they might have to you know, to recover from that illness, and whether they have the support to recover from that illness as well. So this growing and impacting. So we looked at adolescence, the impact of a HIV diagnosis, and then what's the impact for us as health services, for the delivery of our services. We're also seeing a change in our epidemic, aren't we? Less children being born with HIV, so less number of children that we're having to look after in paediatric services, but we're seeing a bit of a middle bulge of adolescents, and I think that's what it's going to be like for definitely in the next 5 to 10 years. So we're going to have this bulge of young people that we need to look after, who are sometimes a bit lost, aren't they? So no one wants to take responsibility of them, because they're not pediatrics and they're not adults. So I don't have the expertise because I'm a pediatrician. Or I have one colleague when I worked in the UK who came to me and she said, "Quickly, Alice, she's got boobs." You know, she would quickly shove me off so I could speak to this young girl about sexual health, because all of a sudden she came back from holidays and she had boobs. So you know, I think, and you know, as pediatricians, it's I think for a lot of healthcare professionals, it's very difficult to talk about, especially things about sexual health. There was a study done in the UK with GPs, and they were asking them how often do they talk to anybody that comes in about sexual health. I know my GPs never ask me if I'm sexually active. So, and when they asked them, it was all the same things. They don't know what to say. They don't want to offend. They don't know what language to use. They don't know what to do with the information once they've had it, if they've got it. And this is not just an African problem, okay? Talking about sex is not just an African problem. It's a universal problem. And you know, a lot of these conversations are quite uncomfortable. They're not normal conversations you have on a daily basis. So yes, how do we, as healthcare professionals, how do we gain that expertise or deliver our services in a way that we can provide good treatment and care to these young people? And then it's you know, this is a lifetime disease. This is through the whole lifespan, isn't it? And how do we look after that young person through their whole life to be attending services and to taking treatment? Okay, it's that transition and making sure that it is smooth for that young person. And the reason why we set up an adolescent clinic and a transition clinic with Great Ormond Street was because what was happening is that they would eventually, at 18, they were no longer allowed to attend Great Ormond Street because, yeah, they just can't. It's a children's hospital. So then they ended up being where I worked in Water Market, and there was no, you know, they'd gone from being wrapped up in cotton wool to just being left. So it's providing that transition of a safety net for them to gain independence in their healthcare. So really our aim as healthcare workers providing treatment and care for adolescents living with HIV is to assist them to have healthy, active, long lives. And we do that by ensuring they come to our services and they stay there and they take their treatment, okay? Seems quite easy, doesn't it? Not really. Easier said than done. So here are just a few examples of other things that are happening when you're trying to get young people to come to clinic. You know, a lot of them, they either been kicked out of home or can't come, I've been dumped by a boyfriend, or I got a new girlfriend, or I've got sport, or Alice, I have to go to university, I can't come all the time. You know, and you might see jail there and laugh, but we actually had more young people more young men going to jail than we had young women pregnant. So, you know, these are real life issues that young people are facing. They're still doing life, you know. In my thesis, one of the boys, he said to me, it's not like I think about HIV all the time. I have a life, I'm a young person. I go to school, I play soccer, you know, I have a girlfriend. I don't think about it all the time. I normally only think about it when I come to clinic. So these are kind of all the things that are going on for a young person. And then what's going on for us? Some of us feel like we don't have the training that we need, or we can't communicate with young people. We all know the groans, the grunts and groans of a young person, don't we? It's like an international language of a young person. Difficult to communicate to them. We don't have time. Especially in the South African context, you guys are busy. You've got lots of patients to see, lots to do. You don't have the space to be able to provide those services that you want to. And then you might not even like adolescents. I had a pediatrician say to me the other day, but Alice, I don't even like them. Give me a baby or a toddler. I don't like adolescents. So this is a very good place for us to start, okay? I always say when we're doing the youth-friendly service facilitation in individual clinics, I want one member from each multidisciplinary team, you know, to help to come up with a plan. But I want them to like young people. I want them to like adolescents. Otherwise, I don't want them anywhere near this, because I think that it's quite key, and it might not happen straight away, and it might take time for you to get used to dealing with them and practice. Personally, the challenge of adolescence I love. There's nothing better than a grunting young person who in a few months' time I can get to having an actual conversation with them. They're constantly evolving. I had this one young girl who, when I first met her, she actually told me to F off. She was born with HIV, but she was only diagnosed when she was 13. So she was not very happy. She had been sick the last couple of years and no one had diagnosed it. And you know, she had a very complex family situation. And here she was, unwell, being told that she has HIV. Not happy young girl. You know, a couple of years ago, she came to see me, and I did spent quite a bit of time with her, teaching her about HIV, getting to understand meds. She had to go on treatment straight away. Lots of that for a very long time. Even times we'll go through a whole consultation, she doesn't say a word. To me, I think, right, okay, I can do this. And now, you know, before I left that clinic, she is a peer support worker. She is undetectable, she's going to university, she's studying law, she's been able to get her own apartment. You know, all these things, they're evolving, things take time. It doesn't happen straight away. And I think in HIV care, we are in the best position to deal with young people because there's continuity. Some people see them every month, you know, some people every 3 months. So you get to know that young person and you can build upon what you've talked about last time. Or you can, you know, discuss those issues and see how they went and re-tackle them again. So I just want to get a bit of idea if someone here would like to share with me some of the challenges that you yourself as a clinician or your service are having in providing treatment and care for adolescents living with HIV. Anyone here want to? Yes?
The adolescents are quite nice to me. I like talking to them, although sometimes they don't talk back. But my problem are often the parents.
The parents, yeah.
That I wish I could keep the parents out.
Yes, okay.
Well, I do see the patient quite often alone and then call the parents in. But quite often the parents are my stumbling block.
Okay.
Not accepting HIV.
Yes, and that's something that personally I've come across, and the research that I did in KwaZulu-Natal, I did interviews with healthcare workers, and parents were one of the biggest stumbling blocks, especially when it comes to disclosure. Anybody else want to share a challenge? I like to call them challenge, not problems. Challenges. Anybody else? Yes, sir.
In our institution, you find that maybe the adolescent has grown to be an adult now. So that they have to move from being adolescent to adulthood, meaning they have to transfer them to where adults are getting medication. You find that they don't know why.
Yeah.
So there'll be those that will say, no, but if he or she is not prepared to maybe to take medication at adult, where adult does, then it's okay. They keep them there.
Yeah.
You may find that they don't want to be maybe to go for treatment with the adult.
Yeah. I think a lot of what we do with adolescents, because there's so much variation, it has to be developmentally appropriate, doesn't it? And that's with our information that we give them, but also how we transition them through services as well. Whether the young person is ready, sometimes the young person is ready, maybe the clinicians aren't. I've had that before, and the young girl ended up, by the time she got to me, and we did her first STI screening, she had chlamydia. Personally, I thought she should have come years before, but the clinicians didn't feel that she was ready. Does that make sense? So it's a balancing act, isn't it? It's like respecting the views of the young person, the parents, and then the clinicians as well. I mean, we'll talk about that more in terms of disclosure. Anybody else? Yes, sir.
I'm thinking that one of the reasons that faces professionals when it comes to autistic adolescents is also in their parents understanding this illness is the stigma that is put into sexual activity. Because most of the time one disclosing, having to disclose that they are HIV positive, it's not the fact that they are HIV positive, it's just the fact that someone might know that they have actual sexual activity.
Yeah.
Just like if you go to a pharmacy and you buy condoms, or you see someone buy condoms, so yeah, that person will have that in that fear that okay, I can't take this condom because
Yeah.
even though they know that they're taking the condoms for protect themselves, but just the thought that this person might think that okay, I'm sexually active, they kind of hold back instead of So if you can just break that stigma about sexual activity, then disclosure and HIV stigma will be broken.
Thank you very much. I think a lot of what you're saying and what the other people have said as well are quite universal things. You know, I've seen lots of clinicians and young people struggle with that a lot. And hopefully when we talk about youth-friendly services and being a youth-friendly healthcare worker, we can discuss some of our own judgments and our own, the ways that we view young people and making sure we do what's right for that young person. Yeah, and you know, all of that takes time. That's a societal change, isn't it? It's not an overnight thing, but I think as an individual clinician, you can do that. And I'm pretty sure if young people find out that there's a nurse that doesn't judge them or doesn't condemn them for being sexually active and actually listens to them, you're going to be a very busy nurse, okay? So thank you very much for sharing some of your challenges. So now we're just going to focus on those key areas and give you some kind of practical insight as well. Hopefully that can help you tomorrow when you go back to work. Maybe lots of you are doing it already, so. Okay. So effective communication, or communication, it's the foundation of all our interactions with young people, and being able to communicate with them properly, it's fundamental to be able to do adherence or sexual health or disclosure. Without that trust and respect with the young person and getting them to open up, you're not going to get very far as a clinician. So this picture here, it's a bit of a famous picture actually. This is from the WHO consultation that I did, where I asked young people, HIV positive or not, about what strategies could we use to get young people to test for HIV. And this is from a girl in Zimbabwe. She drew this. And what that is her healthcare worker. So she drew that and she stood up and she said, if our healthcare workers were like this, more young people would test, okay? Big ears to hear, okay? Small mouth to talk. So in terms of communication, this is what young people are asking for. There's a few other quotes there. The top one is from that same consultation. They ask, why are you having sex? You know, which is, you know, possibly not the best question to be asking, but the one that's worse afterwards is, why can't you wait? So kind of what you were talking about before. The other two are from my thesis from 2 young people, and they said healthcare workers that listen and understand you. You know, that's what we want as young people living with HIV. We want to feel appreciated and not judged. Okay? So, yeah, try and remember the big ears and the small mouth. There's very good representation. One thing I always laugh about is that, yeah, numerous times when I've done talks about communicating with young people, healthcare workers, I remember this one particular in KwaZulu-Natal, she put up her hands and she said, Alice, but what do you do when they are all liars? and I had to laugh because I think that's how a lot of people view young people. And how I came back to her, I said, okay, why do you think they are all liars? Why would a young person be lying to you? And then she was like, oh, yes. Okay, I see what you're saying. And I've said this before in another training, and then when I said, oh, because we all know young people lie, and everyone, oh, yes, yes, young people lie, young people lie. Young people lie, adults lie. We all lie. It has a lot to do about respect and openness and trustworthiness, you know. You know, when my GPs ask me, how much alcohol do you drink? Oh, you know, two units a week. Who's done that? Or do you smoke? No, I don't smoke, just for the record. Yeah, so I think in terms of feeling that you have trust and respect with whoever is providing your care, yeah, it's kind of the foundation for you to be able to get that information, but also to give the information. What it also does through the effective communication for ourselves, it helps us to really understand what's happening with that young person, what is really going on. Because if you can't communicate with them, you don't know why they're not wearing condoms all the time, okay? You don't know how you can help them or support them properly. And the same for adolescents. By communicating effectively with them, you help them to understand how they're actually thinking and feeling. You help them to understand what to do and how to go about changing their practice so they can make informed decisions. And without that trust and rapport and respect, that's not going to happen. So you can establish trust and rapport through really a few key simple things. It's by really understanding what that young person is saying and their feeling and their mindset, and that just takes time to listen to them and also to reflect back to them what they've said. So they say, oh, Alice, you know, sometimes I find it very hard to talk to a boy about whether we should wear a condom or not wear a condom. I found that very difficult. And then you can say, oh, I see what you're saying, that it is quite difficult. Tell me how it's difficult. So it's listening and it's reflecting back to them. By ensuring confidentiality and making sure that that confidentiality in your consultation is really explicit, even before the consultation starts. So if a young person comes in, you would say to them, so everything that's said here today is confidential, but if there's something that makes me concerned about your safety, I'll have to talk to someone else because I might not have the skills to be able to help you. But I won't do it without telling you about that first. So you make it very clear and explicit for that young person. So lots of young people from my thesis and the consultation will say, Alice, but if I tell her something, she's going to go down the road and tell my auntie. Okay? We all know that that's not supposed to happen. We're legally bound as clinicians with confidentiality. But if you don't make that explicit to a young person, they're just going to expect the worst, aren't they? So if you make that explicit, I think that really helps. Being not judgmental. And that's not just within our language, it's with our body language, with our facial expressions. So many times I've heard things from my patients that wanted me to literally bang my head against the desk or have a big sigh or hold my face or, what do you mean you didn't take any of your medication last week? Okay, so those types of reactions aren't going to be beneficial to anybody, okay? So you need to get a really good poker face. And then it's ensuring that you have empathy for the situation that they are in, and that really shows you understanding their thoughts and feelings. And then also showing a commitment to help. So if you don't necessarily have the skills to do something, you can say you can always ask somebody else for that help. And then being honest when you don't know the answer for something. And all these small things that you can do, which don't take resources, they might take a little bit of extra time and a little bit of training, but those simple things, you can ensure that you have a better rapport with your young person, and then you have a mutually beneficial discussion in your consultations. One way not to establish rapport is by telling them what to do or imposing your beliefs on them. Okay, that's the same for adults. It's the same for you and me, isn't it? Someone tells you what you do, you always want to do the opposite. So simple things you can do. You can start the session by talking about non-threatening things, like last time you said that you were trying out for the soccer team. How did that go? Okay, or, oh, it was holidays. What did you do in your holidays? Or, how's your mum? The mum is still around. You know, these are really good ways that you can show that you listened to them last time, or that you're interested in them as a young person. You can also reduce stigma about certain issues like sex by normalizing it. So saying things like, you know, being HIV positive and being a young person, it's important that we talk about sexual activity. I talk to all my young people that come to this clinic about sexual health. So it's important that we discuss it today. See how you normalize it rather than coming out and just saying, do you have sex? You're probably not going to get the right answer. So normalizing it first, that always helps. Then yeah, active listening, showing interest, asking open-ended questions, you know, to get away from that the way around that is to ask open-ended questions where they are forced to give you more than a one-word answer. And then, you know, use understandable non-technical language. We are very good at acronyms, aren't we? We use them all the time, and our patients don't understand them, especially our young people. Also, you know, it's not just our complicated language, but it's also us not using their language. Young people in another WHO consultation that I read, it said that we don't want you to be our mothers, our fathers, or our friends. We want you to be our healthcare workers. And that has a lot to do with the language we use as well. For example, a couple of weeks ago, I was doing some training with some youth facilitators, and the one girl was like, oh yeah, sugar snaps. Who here has heard of a sugar snap? Anybody? No, me neither. So I was, instead of going, oh yeah, sugar snaps, I've got no idea what you're talking about, I said, oh, what's a sugar snap? And she said, it's a collective term for sugar mummies and sugar daddies. And I went, oh, okay. So it's a collective term for men and women who use gifts and money in exchange for sex and relationships. You see how you bring the two levels of communication together so you're on par to understand. And the same can be used, especially with sexual health terms, because I know with young people they change by daily basis or depending on what school they go to. So one thing for oral sex can be, you know, very different from one person to the next person. So it's making sure that you understand, you know, that you come to that level. You meet each other halfway and use that basic language that you both understand. So just quickly on confidentiality, it's just an adolescent perspective. It is a US study, but 86% of adolescent females that were attending a family planning clinic, this is like statewide in the US, said they were willing to use confidential sexual health services offered in a local clinic, okay? But if their parents were notified, 83% of them would stop using services. 57% would stop using contraception and begin using condoms instead. 29% would have unprotected sex, so if you told their parents they were going to a family planning clinic. And 6% would delay testing for treatment and HIV and STIs, and then only 1% would stop having sex, okay? So if you're telling parents that young people are sexually active, only 1% are going to stop having sex, all right? So it just gives you like a little bit of insight, because, you know, in our brains we think something else, don't we? If we talk about sex, they're all going to want to do it. Probably doing it anyway, okay? All right, how are we going for time? 15 more minutes. So I'll start adherence. So we know that adherence in adolescents is worse than children and adults, and adherence weans over time, okay? And that's what we need adherence to be maintained over time for a young person that's been born with HIV that has to take treatment for the rest of their life, okay? So there were a couple of studies that one was done in South Africa, and it showed that after 48 weeks, only 27.3% of adolescents were virologically suppressed. It's a bit scary. Another one for sub-Sahara Africa said that 50% were less likely to maintain adherence, and 70% were less likely to achieve virological suppression when compared to adults, okay? And then a UK national audit that we did when we were asking young people about taking their treatment. So for 95% of the time, we know that you have to take treatment 95% of the time to remain virologically suppressed. And only 62% of adolescents that responded said that they actually took their treatment 95% of the time. So yes, it's a little bit worrying. So the challenges with adherence, especially in adolescents, is that a lot of them are really treatment experienced. You know, especially those who've been born with HIV. They've been exposed to lots of different medication. And in terms of maintaining medication for the rest of their life and long-term treatment, we have quite a few challenges ahead of us, especially in terms of drug resistance and available options of antiretroviral therapy. And it's about preserving those drug options for the future as well for that young person. There was a survey done in Zimbabwe, and it asked, I think it was like 131 different services in Zimbabwe that were providing treatment to young people. What's your biggest concern? And they came back, and the #1 concern was adherence. Healthcare workers, we're all struggling with adherence, you know, even in adults, but particularly with our adolescents. There was a South African study that showed increased drug resistance was seen in pediatrics compared to adults, and 91% of children that were failing were seen to have drug resistance. Okay, again, a little bit worrying. And then in another UK study, then in the London clinic, 21% of the adolescent patients in that clinic already had dual class resistance. Yes, so got a lot of challenges ahead of us. So in terms of young people, what they found helps and what doesn't help. The UK study, they found that reminders, support from family, not having to keep HIV a secret all the time, you know, whether it's hiding your medication from your siblings, or, you know, going to a sleepover and having to hide that as well, that all really, you know, hinders young people taking their treatment. In my research in KwaZulu-Natal, young people said that having understanding and respect for healthcare workers would help them to take their treatment. Knowing the truth about their status earlier would also help them to take their treatment, so they know why they're actually taking these tablets. And then also understanding HIV and understanding antiretroviral therapy. One young person said, when I go into my doctor, I want to know what he is saying to me. I want to understand what he is saying to me. They want practical advice of how to take their medication, how to remember it. Things that hinder. A big US study showed that alcohol use, depression, high pill burden, and complications of day-to-day routine. You know, as I said at the beginning, these are active young people. They have lots going on in their lives. And how do they navigate attending clinic and taking treatment every day around that? Okay. So just quickly, a few what we call guiding principles, things that can help on a daily basis when dealing with young people living with HIV. So in terms of adherence, it's to facilitate autonomy and self-reliance. Again, the safety net, if you remember the safety net, it's about helping that young person to become independent with their medication, independent with their healthcare. And things you can do is you can engage that young person in the consultation. So you're talking about difficulties with parents. It's about talking to that young person, listening to what they have to say first before you address the concerns of the parent. It's a huge shift for parents to get used to, and I think it can be done, again, the continuity of care. We've got time to do these things. And then it's about offering to see them independently or with their caregiver. And this all needs to be set by the pace of the young person. Not all young people want to be independent straight away. Some of them do. Some of them, some of them feel that it's a necessity. In my thesis, one young boy said, "Alice, at the end of the day, I have to know about my treatment. I have to know how to look after myself because I have no one to look after me. I might have some auntie, sister, or someone coming as my treatment supporter, but she doesn't look after me on a day-to-day basis. So I need to be independent. It's a necessity." And you can discuss the importance, why it is important for them to start exercising their independence in healthcare with that safety net, and do that with the caregiver. It's always very helpful. And then again, it's being set by the adolescent and supported by the caregiver and the health provider. Okay? Another thing you can do is assessing the adherence of the young person in a way that empowers them. So it's about identifying the reasons why they're not taking their treatment. And it's using questions to explore their non-adherence. So, for example, you would say, how many medications have you missed in the last week? They might say 1. How many did you miss in the last month? 4. Okay, think about the times where you took your medication. What happened in those times that help you to remember to take your medication? Think about the times that you didn't take your medication. Okay, how was that different to the time that you remembered? Okay, and then it might be, oh yeah, well, I was busy, I was after school, I played football, and then I went to my friend's house because they have a TV, and then I realized that it was a bit late to take my medication, and by the time I got home, I'd totally forgotten. Okay? And then it's okay, so how can we overcome that problem? Do you need to carry, when you're doing sport, do you need to have your medication in your bag with you? So you can take it when you're out at your friend by just going to the bathroom and taking your medication, or just asking for some water or buying a cool drink. Okay, simple things like that. But those types of questions, instead of saying, how many medications have you missed? 1. Why? Why did you miss that 1 this week? It changes the tone, and it gets the young person to reflect themselves to actually understand, because lots of time young people don't know why they missed that medication. And then it's also to go beyond the what, okay? So to understand, to ensure that the young person understands the why. Why do they have to take these drugs? And I'm not saying explain to the young person about the RNA and the DNA and all those things, fusion inhibitors and all that stuff. That's not what I'm saying young people need to know. Find something that works for you as a clinician, something that's simple, a picture that you can draw. That's what I have. My adult patients call it Alice's Ladybird Guide to HIV and antiretroviral therapy, because I just explain very simply in 5 minutes how HIV affects the immune system and why you need to take this treatment and why you need to take them in combination. And then what happens when you don't take the treatment. You can say, if you don't take your treatment, you will die. To a young person, yeah, that's not really, I feel healthy now. It's not really, it doesn't sink in, does it? But if you explain how that resistance develops, they have a better concept of why I have to take that medication. Yeah, and you definitely avoid negative phrases as much as you can. Not helpful to a young person, because 9 times out of 10, that's the only thing they'll remember. So if you draw all that, spend all that time, and then say 1 negative phrase, that's what they're going to remember, okay? And a lot of this, like the drawing that I do, I repeat it when the young people come back. Remember last time I did that really bad drawing? Yes, Alice. Okay, do you want to do it again? Do you understand where there's parts of it you didn't understand? And that continuity again helps the young person to really grasp what's going on. Okay, again, they have active lives. Assist in fitting ARVs around their active lives, whether it's pill boxes or alarms on mobile phones. The reminder is a trigger. So I had one young boy who really, his problem was that he'd just forget. Far too busy, just forgot. So I was like, okay, what do you do every day? What is something that you do on a daily basis? Do you brush your teeth every day? No, not really. Okay. Do you shower every day? No. Like, you're not giving me much to work with. Okay. Do you have breakfast at the same time every day? No, sometimes I wake up really late. Okay. So in the evening, though, he checks his Facebook pretty much around the same time every day. Okay. So I tried to get him to associate, probably not the best, associating, I'm going to go check my Facebook. Ooh, I need to take my treatment. Does that make sense? Whether it's his ARV bottle next to his computer or, you know, there's so many different things. I have young people that have their ARV bottle next to their toothbrush. It's just finding what works for that one young person, okay? And it's exploring with them. Maybe it won't work for them, what you suggest. You have to try something else. It's about being creative, thinking outside the box with the young person, not for them, but with them. Then adherence needs to be constantly revisited. Taking medication is a lifetime thing. It's not something that you address before they start treatment and leave it until they're not taking it anymore. This is something that you need to talk about in every single consultation. And you know, it's acknowledging that this is a challenge. This is something that's quite difficult for a young person. Praise them for what they're doing. It goes so far. You know, you're doing really well. How many of you remembered compared to like a year ago when your viral load was 2 million? You know, you take the things that are good for them. And again, it's keeping that open and trustworthy relationship. Because when things do go south, they tell you. They don't pretend that everything's going good. And then that's encouraging them to be honest and drawing on their strengths and getting them to identify people around them that they can draw on. And another thing is getting them to discuss with other young people living with HIV. It's very powerful because we as clinicians sit there every day behind our desks telling people what to do, but we might not necessarily have that same experience. And for that young person, even though we listen to people all day, every day, that's not what that young person sees. They see that 10 minutes with you. But talking to another young person who's living with HIV, who has to take treatment every day, and how they've overcome those challenges, and how they've succeeded, yeah, it's almost priceless. But that's not for everybody. You know, some young people don't want to know other young people. It's just really working with that young person. And what I want to move on to next is disclosure. And before we were discussing about dealing with parents of the children. And I think a huge challenge comes when it comes to disclosure for the young person to find out their status. And during some of my research, I found this this comment by a researcher in Sweden when they were talking about disclosure. And I think it's very interesting if you have a read. So it's the intersection of human rights, okay? The rights of the young person to participate in decision-making of their own care, the right of the parents to protect and raise their child, and also potentially protect their own diagnosis, and also the right of the clinician or the health provider to protect the people that are involved in their programs and services against from harm, but also promoting health at the same time. So you've got this massive intersection of all these rights that you have to be respecting in that situation, okay? It is a complex place to be in. But I think really it starts with discussions from a very, very young age. And again, it's not just normalizing, but getting parents used to the fact that this has to happen. And it's revisiting and rehaving those conversations with the parent by themselves. And really, I think, though, you'll be very surprised how many young people already know. If you think about your clinic where you are, how many posters are up about HIV? How many pamphlets do you have on your desk about HIV? Children are smart. They're very observant. I had an example from one of the ladies that was in the workshop a couple of weeks ago, and she said that one of her patients went to school with some tablets that she had, and her friend said to her, "Oh, my mum takes those." She goes, "Oh, really? What are they for?" "They're for HIV." "Ah, so that's how that young girl found out. Also, we're in a society where HIV is very publicized, isn't it? We're not hiding it anymore. So these young people are exposed to all those messages, and I think the way that we deal with disclosure, I think it can really affect the young person of how they deal with their diagnosis. It goes hand in hand. And one of the young boys in my research in KZN, he got up and he said, "You know, Alice, I came all the time. No one ever told me what was going on. And then one day when I was 14, somebody told me that I had HIV. And I thought you die from HIV." So I got up, ran out of the clinic, went to go and run into the street to try and kill myself, because what's the point? I'm going to die anyway. Okay, so that's experience of a young man that hadn't been prepped in terms of understanding health illness or understanding why he comes to clinic, or and also he said that again he had stigmatized people that had HIV, and here he is finding out at 14 that he has it himself, and having to deal with that. And I think parents are, you're dealing with fear of other people finding out their status. I had another young man who's about 18 by the time I left, and he really wanted to tell his sister, who was his best friend, that he had HIV, but he couldn't. His parents wouldn't let him, because then it would disclose their status. So as much as he loved his sister and really wanted her to know about it, he couldn't, because of the ramification on his parents. So there's very intertwined issues here that have to be dealt with very sensitively, and I think it's a longevity process. I don't think it just happens like that. I think that's the most harmful way for disclosure to happen.
Alex, can I ask you?
Yes.
Again, my problem with the parents. Quite often in the younger kids, the nanny or an aunt is the supervisor of the tablets, or somebody is staying in their home.
Yeah.
They take the labels of the medication. They do not want to put the medicine next to the kettle or the toothbrush.
Yeah.
It's hidden away in
Yeah.
the cupboard.
Yeah.
So it's the parents not wanting to make their status known.
Yeah.
How do you educate the parents? And also, the parents quite often don't understand what the children's problems are regarding learning, choices in subjects at school. That's my biggest problem.
Yeah. I think firstly with disclosure, it's a societal problem, isn't it? It's something that's far greater than our consultation room in our clinic or the home of the family. We have massive issues in this country and worldwide in terms of stigma and discrimination when it comes to HIV and the negative associations. So I think it's a balance of being understanding of that parent and understanding, if you do leave it open and then your friend comes and then they see you taking Truvada, everyone knows Truvada, or tenofovir is for HIV, and then the whole place knows, And I have had a number of patients have very negative situations when they've told other people about their status. So it's a very fine balance. And to be honest, I have helped young people how to hide their medication from other people, because that's what that young person needed. Okay, as much as I would love them to be out and proud about their status and telling all their friends about their meds, that's not their reality. I think with parents, I think that it's almost like in pediatrics and the beginning of adolescent stages, you're dealing with two patients. And I think it is very beneficial to have individual conversations with that parent without the child, and have conversations together. And I think it's about them setting the pace, but also it's a partnership, isn't it? Because we know, and you can say this from studies, in terms of earlier disclosure, you have benefits for that young person later on. So I don't know, saying those types of things can potentially help. And I have had in my transition clinic, one mother, well, many mothers, but one particular mother that didn't want me talking to her son at all because I'm going to be talking to him about sex. And she didn't think he was ready to know about sex. So she got very angry at me. So what I did wrong was I should have had them together first in the first time that I met him. Wasn't even talking about sex the first time I met him. But it was to sit down with them together and say, this is why you need to transition. This is why you need to start having conversations about your sexual and reproductive health. And this is the avenue to do this, whether you do it with your mum and you're in the room, or you do it with me, or I give you information and you go home and you discuss it with mum at home. It's up to you. I think if you make things really clear and the benefits of earlier disclosure to a parent, in my experience, it does help. If you just say to a mum, you have to tell your kid, and not really work through the fears that they have or why they don't want to tell, then you're not going to be able to. It will be a negative situation, basically. Does that? Sorry, I think I'm kind of round in circles. Yeah, hopefully that helps. So several studies show that we are not good at disclosure. One of them in Kenya asked 120 caregivers if they had told their children, and only 2 had out of 120. And of those, one was 13 and one was 14. It's pretty bad. We're not very good at it. Here are some perspectives of young people. You might not be able to see this picture, but this is from my research. And it says here, why do I keep coming to this place? Children need more knowledge about why they're attending the hospital. They don't know what they're doing there. Why do I have to come every month and miss school or sport or my exam? To sit here and take medication I don't know why I'm taking. And you see, I keep asking why I keep taking these tablets, and my mum would say nothing. Can you imagine the frustration of that young person not knowing why? You know, and I think also with disclosure, it's not just about the young person knowing their status, especially with adolescents. It's about helping them to disclose to others. And again, it's that lifespan thing, it's that transition, and getting them to that point. And then, you know, how do I tell my girlfriend that I have HIV without her getting upset? These are all the things that young people are thinking about. They must tell us the truth about HIV. And that was the same young girl that said, when I'm 14, I've got too much to deal with. Why don't you tell me when I'm 11? So we know that early disclosure has positive outcomes. It improves adherence. There's less reported psychological distress on the young person, higher intention to disclose to others. That was a big study in New York of young people living with HIV. And it leads to better communication in the family and extended family. So once, I guess, you know, that burden, a lot of parents I've spoken to have that burden that they carry around of the fact that they eventually have to tell their child. And once that happens, it kind of frees up the home for better communication to talk about these things. And it takes away that secrecy. And you saw with the adherence data, the young people in the UK were saying that, that having the secret all the time and the isolation, you know, it hinders their adherence. So disclosure is a process, not a one-off event. I'm sure you've all heard that saying before. I guess in many ways, what does that mean? Well, it depends on your clinic. It depends on you as a clinician. But I know the new disclosure guidelines that came out from WHO last year said that children at school age should know their status and the status of their parents, which I thought was quite interesting. But I really think disclosure is honest conversations over a period of time that provide information and then eventually specific naming of the condition. I know there's lots of great pediatric resources. I'm sure some of you have seen them, where it talks about, you know, the virus and the soldiers that fighting, you know, the infection, and it taking time for the young person to, as they developmentally grow and their understanding, that they understand their HIV with that as they are learning more. So there's lots of great resources out there that can assist you as healthcare workers, especially in pediatrics, for young people to understand. And there's also a poster, I don't know if you've seen it, about disclosure, and it gives, you know, the ages of what conversations you should be having and what action you should be taking. And I can give you I've got a link to that online. So it's good. You can put it up in your in your office or something for everybody to see, so they know approximately this age we should be having these conversations, and they really should know by the time they're 11. They should know their HIV diagnosis. Yeah. So. Also, as I was saying before, find out what the young person knows first, because for so long we go on and we have these conversations backwards and forwards with parents, and we threaten that, you know, you need to tell them now, or, you know, we have these battles, and then we find out the young person knows anyway. Also, they might know for a long time, and they might know the wrong information. You know, that's worse. That's far worse than, you know, them knowing their status too early, isn't it? So really, finding out what they know, build on what they know, modify any misinformation that they have. Lots of young people think they have TB, and they have to take TB treatment for their whole lives. I don't know if you've encountered those young people.
That's what they've been told.
Yeah. No, I'm saying that's what they've been told. Yeah.
Scared parents.
Yeah. Yep. So, yeah, I think that the continual conversation, I think, is key. So ideally, it should involve the parent or the caregiver in an ideal setting. Sometimes that always doesn't happen, especially for young people whose caregivers are always changing. That makes it quite complicated, doesn't it? But having that kind of process in your mind of what age they are and where their knowledge should be about HIV and where their understanding should be, that helps. You know, no matter who the caregiver is, you know that this is this age and this developmental stage for their understanding. So we were saying before, exploring the fears, acknowledging the fears of the parent, trying to understand them as best that you can, and then trying to find out ways to help them. And part of that is equipping them with information. Maybe the parents don't even know themselves. Happens a lot of time. Once I had a patient who was switching his treatment, and then it turns out he didn't even know how treatment worked, and he'd been on treatment for like 20 years. So, you know, lots of people don't know about how HIV affects the body and how the medication works. So helping the parents to really understand, so they can convey and answer the questions. Parents aren't good at answering questions that make them feel uncomfortable, are they? No, they're not. They just rather push it aside. So it's equipping them with those skills and with the information. And then, you know, in terms of discussing how, when and how, and, you know, how it should be done, the environment, the time, make a plan together with the parent. Okay, you've said today this is the fears that you are facing. Let's talk about that again next time. And how about we aim by the end of the year to start thinking about the right time for you to tell your child. So make a plan with the parent. What suits them, you know? Often parents change the plan, you know? Oh, but we're going on holiday. Oh, not next time because he's got a big sport event. You know, there's always something. But try and set a plan and make sure that you make that together with the parent. And then, yeah, I think after naming of the diagnosis, you should really make sure that the conversations continue. Because there's nothing worse than a child being told, you have HIV, and no one ever talks about it ever again. Because we project that this is something that's bad. This is something that you can't talk about. You know, we stigmatize it ourselves by never talking about it again. So it's making sure the parents understand that these conversations need to continue even after they know their diagnosis. Post-disclosure support is essential. That's the next one. And that's not just what we were saying before in the home, but that's also you as a clinician. And it's, you know, I'm not sure many young people are going to come and start the conversation with you. You know, it takes you to initiate that conversation. So last time you found out that you had HIV, how's the last month been for you? What have you found hard? Like, what have been the challenges? What have you been thinking? And And it's exploring those challenges with that young person. And then looking for support, okay? Have you been able to talk about it with your mum or your dad or your granny or your auntie? Have you been able to discuss it with anyone? If they say no, okay, how come? Is there someone that you feel could support you? And then also, again, peer support. Huge fan of peer support. If they've just found out their diagnosis, ask them, would it be helpful for you to speak to another young person that also knows their status now and share their experience? Also, lots of young people have had bad experiences, but I think this is the reality. We can't protect them. We can't tell them that everything's going to be fine and dandy when you tell someone you have HIV, because lots of times it's not, unfortunately, but that's the reality that we live in. So disclosure to others is a right of the adolescent. People find this quite difficult, but it's the adolescent's right to know their status, but it's also their right to tell their status. And this is so key if we want to maintain young people in our services, especially ones that have been diagnosed during adolescence. If you're placing pressure for them to tell their mother or to tell their sexual partner, they're going to run and you're never going to see them again. I had one young man that I was working with for so long about to tell his girlfriend. So he was being safe. You know, we talked about it a lot. We had done preparation where we practiced with each other. You know, I was pretending to be his girlfriend, and then he would tell me, and then I'd ask him a question. He was really prepared for it. And then he was unwell and in hospital, and the consultant that was in hospital found out that he had a girlfriend and flipped, and then threatened to tell his girlfriend. Of course, he absconded out of hospital with like a massive high viral load and, you know, lots of opportunistic infections. And so, and then it took me a long time to be able to work him back to that trust with that young man. Young people can be quite volatile. They can be quite impulsive, okay? I'm not pretending that they're all lovely and sweet, because, you know, they're not all the time. But doing things like that isn't gonna help anybody. Yeah, and I think encouraging, trying to find them someone that they can trust, you know, and working with that, because I could tell you stories, you know, young women who, when they broke up with their boyfriends, they put it all on Facebook, you know, and then everyone found out she had HIV. Someone wrote it on her boyfriend after they broke up, wrote it on her door. One young guy we were working, his brothers and sisters knew his status, and he wanted to tell some of his friends. So we've been working for a couple of months now to get him ready to tell some of his friends, university age, and he came in the next visit, and I was like, how did it go? And he's like, there's no way I'm telling my friends. I was like, what happened? And someone else at his university, someone found out that she had HIV. They'd been sharing the same toilet seat as her, so they were all going to go and beat her up. Okay, so for him, he's not going to tell any of his friends. So we ended up writing a letter to Dizzy Rascal. I don't know if anyone knows Dizzy Rascal. He's a famous rapper in the UK. So we wrote a letter about, you know, societal-wide discrimination towards young people living with HIV. So that was his avenue of dealing with that disclosure. And he just, in the end, he just had to be confident with who he could tell and who could support him. And then I've had other young women who, before they even start relationships with men, telling them that they have HIV and things going really well, you know. So you can't say how these things happen. And even some of them have come to clinic with their boyfriend and told them while I'm in the room, in terms of safety or being able for me to answer the questions they might have because they don't feel confident enough to deal with it. So there's lots of ways to do it. Yeah, and ultimately at the end of the day, it's the young person's wishes that need to be respected. Otherwise you're going to lose them, and that's the last thing we want. We want them to stay in services and keep taking their treatment. Yeah, disclosure is seen as a necessary means of support. So being a young person living with HIV can be very isolating. And having someone to talk to about it really can be very beneficial for a young person. It can help a lot, whether it's support groups or family members. And I think it's important to explore that with the young person in the context of their family, in the context of their friends, looking at sexual partners, looking at the positives and negatives, sorting out, you know, when to tell, who to tell, why you should tell that person, do you need to tell that person. Also in the context of education, the workplace. What's the rights of the young person in terms of disclosure? Those are all things that young people have to think about. I had one young man who, when he found out, when his parents told him he had HIV, he was devastated because he wanted to go to the army. And he just assumed, because of HIV, he can't go to the army. So we got on the internet and I wrote an email, and turns out he can. So, you know, in that thing, it's important that young people know in terms of how it's going to affect the parts of their life, because those are the things that they are currently thinking about. And then again, it's sharing their experiences with other young people living with HIV can also very much help that young person to create that sense of support. Has anyone had much experience about supporting a young person to tell somebody else? Yes, you have. Okay, because sometimes we forget about that. We think, oh, they know, we don't need to talk about disclosure anymore. So it's something always really important to remember in terms of support. Okay, sexual and reproductive health. Sexual risk is greatest in adolescence and young adulthood. Okay, unsafe sex, lack of contraception are main risk factors in the disability-adjusted life years for 10 to 24-year-olds. Adolescents living with HIV are no different. Okay, here's some studies that have some really exciting studies that have been done in the recent years. One was in Kenya, and it showed, I think it was like almost 700 young people in Kenya living with HIV, and it showed that they desire to have sex, they've already had sex, or in the future they plan to have sex. And there was another one in Uganda that showed a third had never had sex before, but 86% of those intended to. So they might not be having sex now, but they're planning to have sex. And then there was the same one in Kenya, 3/4 desired to have children later on in life. Okay? And that despite their desire to delay sex, 68% of the sexually active females, already sexually active females, were already pregnant, had already been pregnant. And 3/4 of those didn't plan, so unplanned pregnancies. That's quite a huge thing there, that we're really not addressing the reproductive health needs of young people living with HIV. In a UK survey, so we did one of all young women living with HIV in the UK, and 1/5 of them had been pregnant, and 75% of them were unplanned. Okay, so in general, internationally, we're not doing very well in addressing not just the sexual health needs, but the reproductive health needs of young people living with HIV. Okay, so perspective of the adolescents. In Kenya and the Ugandan studies, young people said that they were concerned about infecting others. They were concerned about pregnancy, and they were just concerned about serodiscordant relationships and how that would affect their sexual health. And then there was a global consultation with WHO, and young people said that they had inadequate information and they didn't have any information accessible to them. So we have information about HIV, we have information about sexual health. We're starting now to get more of it combined. Not much of it is adolescent friendly. I'm going to give you a link to our website, which I've tried to outsource as many adolescent specific resources for each of these key areas. And there are a few websites and a few things around that you can use for your young people. So here are some comments from my thesis. Sex is an important part of life. We must have more advice about it. How do I get pregnant safely? I want to know how to protect my girlfriend from getting HIV. So these are the questions young people living with HIV are asking. And it's our responsibility as healthcare workers to let them know. Okay, so some key guiding principles. It's making sexual and reproductive health developmentally and age appropriate, okay? Discussions before an adolescent should start before an adolescent is sexually active, okay? So it's not just one day they turn up and say, I've had sex, and then you think, oh, we should start talking about that, right? This has to happen way, way before they become sexually active. And if they're not sexually active, it doesn't just stop there. So are you sexually active? No. Okay, that's fine. Phew! Dodged a bullet there. No, sorry, you don't get off that easily. You need to start having conversations, whether it's about puberty. There's so many things to talk about. Whether it's about puberty, are their friends having sex? Have you thought about having sex? You know, have you thought about how HIV in the future could affect your sexual relationships, or having sex with, you know, a girl or a boy, or etc. There's lots of things to talk about. Other discussion points. You could start talking about establishing boundaries before they have sex. Them figuring out, what do I want to do? How do I want to behave in those situations? Exploring the impact of having a baby or an STI. I had one young lady who came to me and said, Alice, I want to have a baby. So she's 17, she's grown up in foster care, and she's just finished high school, just started first year university. I was like, okay. And then she said, well, I don't want to have sex to have a baby. I really want a family, but I'm not ready for a relationship. So could we research if I could get some sperm? It's not something a young person asks you every day, is it? So, you know, being open and not judgmental as I am, I did my best to, you know, explore this for her, and we had conversations about how she thinks this will impact her life, and the fact that she just got into university, and you know, how it would affect her social life. And we had these conversations about it, and so did our psychologist. And then 3 months later, she came back, and I said, so I found out all this information for you, and you might have to go to America to get that sperm. And then she said, oh yeah, that. No, I want to get my driver's license first. So it helps to explore these things and to talk about them, you know, rather than her just going off and getting pregnant because she wants a child. In potentially an unsafe environment. And then also, you know, abstinence. Some of us, when we hear abstinence, we cringe a little bit because often it's not very realistic for lots of young people. But for some people, young people, it is what they want to do. So we can't just ignore it, but it can't be the only way. We have to be able to discuss all the other things. And I'll talk about more what type of information we should be talking to young people about. So one of the key guiding principles is always doing a good assessment. It should be part of your routine care. Just like addressing adherence all the time, we need to be addressing sexual health because it changes for a young person. 3 months ago, not sexually active. 3 months later, sexually active, potentially pregnant. So it's important that it's, you know, we revisit that thing, to revisit it in every single consultation. So I think it's also important to explain why. So we talked before about normalizing, making it holistic. Because there have been quite a lot of negative experiences of healthcare workers yelling at young people about having sex or about being pregnant, young people are fearful. And there's an automatic assumption that we're going to be angry at them or yell at them if we're asking about sex. And it's uncomfortable, just as much for the young person as for you, you know. But I think this normalizing and having a holistic approach really understands why, it helps a young person to understand why you're asking those questions. Again, we talked about the clear, direct language. And then also not making any assumptions about sexual orientation or behavior or what a young person knows. Because sometimes I think young people know a lot. Turns out some of them don't, okay? Also, I think like one young guy, I thought he had one girlfriend for so long, and turns out, you know, I don't know, 4 or 5 consultations later, that he's doing this thing called linking. I don't know if anyone's heard of it. Again, I had to ask what linking was. So he has a stable girlfriend, but then he has all these other girls that he has sex with, and they form these sexual chains, okay? So I had always just said, you know, I asked them questions about, are you sexually active? What type of sex? Do you have a girlfriend? Yes. You know, I didn't ask how many partners. You know, key information that I was missing in my assessment. So yeah, and I think there's some useful questions here, but we have what we call like takeaway documents from our workshop that give you far more, and they're all accessible on our website. But it's asking things like, what type of sex are you having? You know, oral sex, and saying those words, oral sex, they might say, what's oral sex? And then you know, you have to explain that. And then, okay, vaginal sex, anal sex. So if you're not explicit, lots of young people are having anal sex because they don't want to get pregnant. So if you say, are you sexually active? Yes. Okay, do you wear condoms? Yes. You know, and you don't ask them what type of sex are they having, or for what type of sex are they using condoms, or are you using condoms sometimes, never, or always? I find that always really helps, because it's easy to say yes, no, when you're asking about condom use. Yeah, and then, you know, have you had any new partners? Is it a casual partner? Is it a regular partner? And then you start to tease out all those extra bits of information that we could easily glide over and not address at all, which can be quite dangerous for that young person. And I think the key also to a good assessment is getting the information from them, but it's also assessing their knowledge. So you want to get the information so you can provide them with good care, or, you know, but what it also is assessing their knowledge and their understanding and their practices so that you can give them information as well. Do you see that? So it's not just you want to know because you want to know. You want to know so you can help them to make informed decisions the next time. All right. So what type of practical information do we need to be giving? And this is about safer sex, going beyond abstinence. I think young people should know about different types of sex and the risk of HIV and STIs for those different types of sex. I think they need to know ways to reduce risk. Okay, if abstinence, going beyond abstinence, ways to reduce it, and that's reducing partner numbers, adhering to your antiretroviral treatment, finding other ways to pleasure yourselves, if you know each other, if you're not in a position where you want to have vaginal or penetrative sex. Okay, these are all things. Avoiding substances that impair your judgment, and again, that kind of conversation about ARVs, you can use it for condoms. So. Do you wear condoms? Sometimes, never, or always? Sometimes. Think about the times when you do use it. Do you use a condom? How is that different when you don't? And a lot of the time, it's about power imbalances. It's about being in situations that they don't feel comfortable in. It's about impaired judgment because of substances. And then instead of you saying, oh, you were probably drunk, so that's probably why you had unprotected sex, they think, oh, I think I had too much to drink that night. So maybe that's why I didn't wear a condom. Maybe I should be careful about how much I drink, you know? So you're getting the young person to come up with their own solutions to their problems. I think young people should know about signs and symptoms of STIs and seeking out the treatment they need. How to use a condom. Who here regularly does a condom demonstration for their young people? Okay. That's something that needs to happen, you know, very quick, very easy, 5 simple things that a young person needs to remember when it comes to a condom demonstration. It's about also doing male and female condoms, so giving women the option as well to use a female condom. Some of our clinics don't have access to them, but it's important that we acknowledge that they are available. And then condom negotiation skills. Again, role plays or discussing it with the young person also really helps. And I know that time pressure, this isn't always achievable in the time that you have with a patient, but it could be sourcing out the other people that work with you, your lay counsellors or your nurse, or somebody else, to also have these conversations with a young person if you don't have time. Or in the support group that might happen for your young people. These are the types of things that they need to be finding out about in their support group. And then available family planning methods. And again, it's a continual process. Okay. So ensuring they have access to condoms and family planning methods. Be discreet about providing condoms. I know lots of places, the condoms are where you first walk into the hospital. No one's going to take them. No young person is going to take condoms if it's visible for everybody. Put them in a bag, do it behind a closed door. Then young people are going to take them, they're going to use them, okay? Offer them every time that they come, and then help them to figure out where they can get it for free in their local area. You know, do they have a family primary healthcare service close to them where they can access it quickly? Where can they get cheap condoms from that they can buy? All those things are very important. And you should discuss these things with both males and females. Okay, it's just not, these aren't conversations that are reserved just for girls, okay? This is both. It's a responsibility of two people coming together to a sexual act, condom use, okay? And then in terms of family planning methods, if you don't have them in your clinic, find out where they are available. How can you refer? Establish links with a primary healthcare clinic that does provide it. Send referral forms. Follow it up with the young person when they come next time. Okay? So we were talking about before about young people having that desire to have children. And I think we really need to help young people to look towards the future because they are thinking about these things. They do desire to have families. And it's exploring that impact with that story I was telling you before on their, you know, the economic situation, their studying, their social life. And then I think that, you know, that even though they might not want to have kids now, I think we need to really help them to think about how they can have kids in the future. So preconception advice. Not that you're telling them now that this is how you can have a child, but they ask, these are the thoughts that they're thinking. I want to know how I can have a child in the future. Is it possible for me? Can I have a negative child? Yes, you can. There are lots of young people who don't know that. You'll be very surprised. They don't know about PMTCT, okay? And I think, you know, with preconception advice, it's about, you know, how it works for negative women with a positive man, how it works with a positive woman with a did I say that twice? So a positive woman with a negative man with a negative woman, and then two positive people. How can you have a baby together safely? Okay? And it's our job to provide that information to the young person, even though they're not ready to have a kid in the future, okay? I met one young lady at a clinic in KZN, and she didn't want to start taking her treatment, and she didn't want to start taking her treatment, and when we spoke to her a bit more in depth about it, it turns out that she had been told she'd go on efavirenz, and with efavirenz you can't get pregnant. So she didn't want to go on it because she wants to have a child. So she wasn't explained to her that on that medication it's not advisable to be pregnant. And if you want to be pregnant, you need to go on someone else. She just thought it would take away her chance of being able to be pregnant. So it's important that we make those things very clear to young people. Okay, last one, youth-friendly services. And then we'll have time for questions at the end as well. So what do you think are important aspects of youth-friendly services? Come on, somebody. What's an important aspect of a youth-friendly service?
That the youth is the center.
Yes?
Not the adults or the doctor.
Fantastic. Big ears. Yes, yes, big ears. I've had some people that think that youth-friendly services is that the building has to be cool colours, there has to be music, there has to be free food, you know, possibly like some sort of Xbox entertainment. But to be honest, when internationally I've looked at lots of studies, and from my own research and consultations, when you ask young people what are the most important aspects of youth-friendly services, this is what you get. And this doesn't cost any money. This doesn't take any resources, doesn't it? It's kind, non-judgmental healthcare workers, and it's confidentiality. This is what is important to young people. So youth-friendly services, what does that mean? Good question. There's lots of different definitions out there when it comes to youth-friendly services, but most of them include those aspects. So respect, convenience, non-judgmental attitudes, diversity, affordability, confidentiality. The International Planned Parenthood Federation said that youth-friendly services have a comprehensive awareness of what young people want, not what adults think they want, which is, I think, is key. And then UNICEF says that they're welcoming spaces where an adolescent can feel comfortable. Okay. So we talked about before, at the very beginning, that we want to keep young people retained in services and on medication. And I really firmly believe that youth-friendly services help to do this. And by retaining young people in services, we're affecting their life expectancy, their quality of life, preventing new infection, and also the cost to healthcare services. So small changes that you can make in your clinic environment can save costs further down the line, whether it's your young person that you've lost to follow up and then they turn up and they're exceptionally unwell. It's going to cost your service more money than providing a service that's youth-friendly. So we look here, the first statistics are from a study of 13 countries in sub-Saharan Africa. So this is all patients, it's not just young people. But it showed an overall rate of 70% at 3 years after starting antiretroviral treatment. I don't think that's too bad, 70%. I don't know what it's like in South Africa. I don't think anyone's done a study to see what the retention rates are. Then in Tanzania, a study showed that young adults, so 15 to 30, had significantly higher rates of loss to follow-up. And I think that could be for many reasons. And it could be also do with migration and going to university and things like that as well. But then in Mozambique, there was a youth-friendly service that saw far lower rates of loss to follow-up than the national average. So that's pretty exciting, I think. Not much research, but something there shows that having a youth-friendly service does improve rates of retention. So, key principles when it comes to a youth-friendly service. I've just got 5 of them. The first one is create a youth-friendly environment. And how you can do that depends on your individual facility, okay? Lots of people have tried lots of different things. A separate waiting area, even if it's around the other side of the clinic, you have chairs just for young people. It could be booking all the young people on the same afternoon or the same day. So also for healthcare workers, it's like, oh, today I'm going to see adolescents. This afternoon is adolescent time. So it helps healthcare workers as well to go from being pediatricians to being able to deal with adolescents. And also young people, I think that they really like, and from my thesis, they really enjoy having other young people around them, and it makes them feel less alone. They realize that there are others who are HIV positive as well. And then, it can have flexible hours around school. That was the #1 theme that came out of my thesis. They don't want to wait for so long. They don't want to miss a whole day of school. Once a month, one girl, she drew a picture of school, and then she drew herself, and then on the other side of the school she drew three girls, and she got up to present her picture and she said, "This is me," who had a really sad face. "Those are the girls in my school. Because I go to clinic once a month on the same day, everybody knows that I have HIV." And she put down to the fact that she wasn't getting along with people at school, and she blamed it on HIV and coming to clinic. So really negative associations about coming to clinic and it kind of taking over their lives, basically. Another young boy, he drew just a very, very fast car. And I was like, okay. He's like, fast car, yes. I would like clinic to be fast. That's all I want. That's all I want from clinic, is for it to be fast. I don't want to wait here for 7 hours. So think, lots of different things you can do. Flexible hours. I heard a clinic in KZN that's having their adolescents come on a Saturday morning, which is great. People really thinking out the box, I think. Yeah, there's other places that are doing I guess they're calling it one-stop shop, where you can see everybody quite quickly. So you have a designated lay counsellor, to do the pill counting, designated doctor, and things are done a lot faster for the young people. Yeah, so there's lots of different things to do. Some places they have activities while the young people wait. So if you're going to have to wait and we can't change it, let's give you something to do so you're not bored. whether that's writing, I wrote to a magazine company and asked them to donate, and they gave us a free subscription, and I think, 6 years later it's still going. So, that's great. So we constantly have up-to-date trash, unfortunately, for young people to read while they wait in our adolescent clinic. And having posters around as well, especially posters that explain the confidentiality. Yeah, I think it just helps to create a more youth-friendly environment. And then being an adolescent-friendly healthcare worker, which I really probably should be number one. Again, those non-judgmental attitudes, being kind, caring, respectful, listening. I think it's knowing and advocating for your rights of an adolescent. And that's through attending workshops, knowing what policies affect young people, knowing the rights of your young person. And then being able, as like a multidisciplinary team is key when it comes to young people. You can't do it in isolation. You can't look after a young person just as one doctor as yourself. You need to work together, and it's discussing, challenging young people with the people around you so that you can come up with a plan for that young person, or how you're going to, keep that young person retained in services. Yeah. And I guess the key to being an adolescent-friendly healthcare worker is always doing what's best for the young person, even if it goes kind of against the grain of what you believe, okay? Or your own personal thoughts. And I think it's a lot about our own professional responsibility to that young person. Okay, so we talked a lot about confidentiality before, so I won't go into much detail about that, but it's very, very key. And I think even closing doors where possible. There's times where I've sat in clinics, open door, shut door, open door, this person comes in, that person goes out, with just, like a 10-minute conversations for a young person. They're not going to tell you anything if people are just swanning in and swanning out, okay? You're not going to get any information. And then decrease workplace gossip, especially in front of young people. I've had young people tell me stories of where this nurse would whisper in that other ear, and they might look at them, even though they might not be talking about their young person. That's how the young person perceives it, okay? Only talk about things that are going to help and be beneficial to that patient. And then empowering them through education and practical information. And it's not just in regards to sexual health, it's in regards to lots of different areas. And it's again assessing the knowledge, addressing the gaps, addressing misinformation, whether it's about HIV, whether it's about sexual health. And I think it's really important to go through the information and explain it. I always tell a story of a particular healthcare worker that used to put a whole heap of leaflets in a brown paper bag and just come up to the young person in clinic while they were waiting in the waiting area and go, yeah, just take this, it's got some leaflets for you. It's not really helpful, to give leaflets in a brown paper bag in the middle of the waiting room. Not beneficial to anybody, again. So, I think those practical demonstrations, using visual aids, it all helps the young person to understand. And then facilitating discussion with peers. I know there's a few things that I'm repeating, but they're really key for each of those areas that we are discussing. Okay. So one thing that I know about the South African context, and before there were all those green things that came out, no time, no space, no resources, don't have the training. This is the reality of where we are. And I really think the answer to this is collaboration. Collaborating with each other within your service, collaborating with other services. I know there's a clinic in KZN that was thinking about starting their own support service, and then they found out that in one of the very big townships close by, there's an NGO that already has loads of support groups for young people living with HIV, and they didn't even know for all this time. And to be honest, me as a nurse, I don't feel like I have the skills to run a support group. I really don't feel like I have those skills, but there are NGOs who are already doing it, okay? Find out what is in your area, find out who's doing what, okay? Map out the services, whether it's a Y centre or, there's lots of community stuff that's going on in South Africa. I don't know, do you know those HIV directories? There's one for each province. have a look, see what's close to you. Use those resources. We can't do this alone. It's too much, too big. Yeah, and I think that, you know, with the IPPF statement at the beginning, it's about finding out what adolescents want rather than what we think they need. And part of that is involving young people. And this is imperative to provide services that are responsive to their needs. And ask them how they want to be involved. Don't tell them how you think they should be involved. It's very difficult, but very simple at the same time. We just have to remember it. You know, provide feedback mechanisms. Is it a suggestion box? Do a survey. Ask them about the services that they receive. How can they be better? You know, have a patient representative. Have a young person, you know, that represents all the other young people. There's lots of different ways that you can involve young people in your services. Do a focus group. Have some of the young people that are in your service, invite them to come around and do a focus group. Maybe it's not very beneficial for you to do the focus groups, and they might not be very honest with you. But if you've made links with other NGOs, invite them in to do like a focus group with young people to find out how services are going for them, or how they can be better, or how things can be improved. And then, yeah, as I said before, facilitating support for those young people. If you can't do it yourself, find out who can do it. So I think part of implementing youth-friendly services, there's a couple of things that I would recommend before you do them or while you're doing them. And I think you need to do a needs assessment, which when you say that, people think public health speak, a needs assessment. But it's very simple. It's like, what are the needs of the young people that we're serving? Map out your service. You know, I followed a few young people through their experience in clinic, you know, and it's quite complicated. You go from here to there, and then you get a slip, and then you wait there, and yeah, it's quite complicated. See how you can streamline those things. And again, I think you need to definitely, again, multidisciplinary approach. And then look at your management protocols. Do they support adolescents? If they don't, how can you change it? And then ensuring that, you know, you're providing training for your staff, the ones that like adolescents, that want to be involved. If they're interested, enable them to be a friendlier healthcare worker to adolescents. Involve young people, and then monitor and evaluate. There is not much research that's been done about youth-friendly service and the impact. There's only that one study on the impact of retention. There's nothing on adherence. There is so much great data that can be collected in developing this that other people can use and see the effects of youth-friendly services. Okay, almost there. So what supportive policies are out there at the moment in terms of youth-friendly services? So we have the National Adolescent Friendly Clinic Initiative, which involves 10 standards. So that's, I think that's way from like 2000, and it came in especially in primary healthcare, and then it's kind of stagnated around, and not much has happened with it. And then there's this new adolescent and youth health policy. Has anyone heard of it? No. Okay, it's supposed to come out this year. They've done a draft and they've had consultation about it. And in that, it has very clear indications about youth-friendly services, and about adherence, and about retention, and then also about testing and counselling of adolescents. So I think it's going to be very interesting to see what happens with this when it's released, and the impact that will have on their services. But if you start doing youth-friendly service stuff now, you'll be ahead of the policy. And then WHO. So some of the work I did was around the kind of service delivery guidance for the development of HIV testing and counselling for adolescents, but they were also working on service delivery guidance for adolescents living with HIV. And then also kind of there's new guidelines coming out where they're looking across the lifespan in terms of medication. So there's lots, I think in the international stage at the moment in terms of adolescent health or youth health, there's a lot going on, and I think over the next couple of years, and I think we're going to have to, because this is where a bulk of our patients is going to be. We're going to have more supportive policies and things involved. So just quickly to conclude before we have questions. Yeah, adolescence is a time of growth and change. The impact HIV has on this process often makes it more challenging for young people. As healthcare workers and health services, we really need to adapt and change with this changing epidemic and with these changing adolescents, so we can provide them with better support. And I think through better communication, non-judgmental attitudes, friendly environments, that we can address the concerns of young people in terms of adherence, disclosure, sexual reproductive health, and ultimately keep them in services and having long, active, healthy lives. So that's it. Cool.